मैं क्या शुरू कर दें
जनरल वर्मा? बिल्कुल राजा जी शुरू करिए.
Should we start, sir? Wait for 20 people? Oh, we start. Okay. Vijay?
Yes, sir. We are live. We can go ahead.
Okay. So, good evening, students. Extreme honor to welcome you once again for the next episode of our Regain PG session, Master Bedside Clinic. And I think it's very honored to have our course directors, Dr. Colonel P.P. Varma, as well as Dr. Vijay Kher for today's program. And as you're all aware, we'll be this will be our 20th episode on this financial year, and we are trying to do our level best to consistently organize and be a part of the student success stories. So we are very happy to have this the first edition of this new year 2023. So on behalf of the entire team, we wish each and every one of you a very happy new year. And now I request Dr. P.P. Varma to take over from here and introduce the examiners as well as students for the over to you, Dr. Varma.
Thank you very much, Mr. Raja. As you mentioned, today, Professor Kher and myself, we are moderating the session. And we have got a very interesting topic in this 20th Master Bedside Clinics in Nephrology. And that is a reflux nephropathy. We know that primary or secondary. Today, to discuss the topic, we have got two examiners, Professor Manoj Singhal and Professor Bhowmik. Professor Manoj Singhal is Director and Head of Nephrology at Max Super Speciality Hospital, Vaishali in Ghaziabad. And Professor D. Bhowmik is Professor of Nephrology at All India Institute of Medical Sciences, New Delhi. They don't need any introduction. Both of them are excellent clinicians, very fine teachers, much sought after teachers, and astute academicians. It's always a pleasure to listen to them or to attend to their class because their way of teaching students is phenomenal. And the student for today is Dr. Anindya Biswas. He is a student with Professor Manoj Singhal. Before going further, I'll request Professor Kher to introduce the topic, and then we can proceed ahead.
Thank you, General Varma. Good evening, ladies and gentlemen. Welcome to this another episode of Master Bedside Clinics in Nephrology. And I think it's always a great learning to go through these sessions. And I can tell you that there is a tremendous learning going to be today as well, because reflux nephropathy is one of the common diseases. It's not an uncommon illness, especially when you see patients in the outpatient clinics. You find patients presenting either with a history which is very, very consistent with reflux nephropathy with recurrent urinary tract infections, maybe a posterior urethral valve, which has been operated in the early childhood, or even urethral implantation in a person who has done it maybe 25 years, 30 years back, and now presents with chronic kidney disease, progressive hypertension and all that. Or patients may be asymptomatic without much history of early urinary tract infections, and they present with hypertension and renal dysfunction. And you find that there is bilateral scarred kidneys on investigations. And you find that this was probably a patient who has had a reflux some time back, but the reflux may have disappeared now, but the damage it had caused in the early childhood is all that is remained and left an impression on the kidneys, and the kidneys are progressive chronic kidney disease. So multiple manifestations of these diseases, and obviously how or what can be done to prevent, if any. Can we do something to prevent the progression of this kind of disease? Is surgery necessary, not necessary? If it is necessary, which patients it's necessary? So all these are controversial to a large extent. There may not be a final word, but every patient is a different patient and has to be tackled in that fashion. So personalizing kind of treatment modalities for this condition would be very, very important. And it's therefore very important to listen to the two experts that we have today. And I'm sure Dr. Biswas will enrich all of us with the amount of knowledge that he may have gained by studying it to a greater extent. I'm sure that he probably is the most knowledgeable guy today. And hopefully the examiners will extract that knowledge for everyone else's benefit. So over to you, Manoj and Dr. Bhowmik, and I will request Dr. Biswas to start the presentation. We will predominantly not be intervening. It is the examiners which will be intervening. We will interject in between here and there just to highlight a particular point or something. But otherwise, basically, I would think Dr. Bhowmik and Dr. Manoj Singhal will do it. Yes, Dr. Biswas.
But please unmute yourself, sir. Biswas.
We can't hear you, Dr. Biswas. We can see your presentation, but we can't hear you.
If you have an headphone, just remove the headphone and speak from your laptop directly, sir. Or just check your laptop mute. You can just, if it is by chance, if it is muted, you can unmute the laptop. We are not able to hear you.
Could hear you earlier.
Earlier we could hear you, now not now.
Yeah, I can't hear you.
Or would you like to rejoin, sir? No, we are not able to hear you. You have a headphone? Do you have a headphone to use? I think he's rejoining, sir.
Good. Good.
Deepak, Atul, can you just call him and help him?
Deepak Sharma is following it up.
Rejoining.
Yeah. We're waiting for him. I think he's joining Anindya Biswas. Yeah, his audio is getting connected. Yeah, good. Sir, we can see you, Dr. Biswas. Hello. Can you hear us, Dr. Biswas? Sir, your audio seems connected. Can you hear us? Hello. Dr. Biswas. I think he's not able to hear us. Hello.
Am I audible? Am I audible, sir?
You are
Yeah, now
audible,
you're
sir.
audible.
Please go ahead. Vijay, just share the PowerPoint.
Yeah.
Yeah.
Am I audible, Mr. Raja?
You are audible.
Yes, yes.
Make it full screen.
You can go ahead, sir. Please, Vijay, make it full screen, and sir, you can start. Dr. Biswas can start.
I'm unable to hear anybody. I'm unable to hear anybody else.
You are, please go ahead. Go ahead.
But he says he cannot hear anyone.
We can hear you, sir. Okay, you are not able to hear us. Sir, I suggest you please try your earphone, sir. We are able to hear you.
Deepakji, share this mobiles.
Yeah, please use your headphone. Yes. Can you hear us now?
Hello, am I audible?
Yes,
are
you are
audible.
audible.
Hello,
Can you hear us?
am I audible?
Yes,
Yes.
sir. Yes. You
Audible,
are-
Am I
audible, sir.
now?
Audible.
Am I
Can you
audible?
hear us? Can you hear us?
No,
No, he
don't
cannot
think
hear
so.
us. Yeah, no, he cannot hear us. That is the problem.
you are
Why
not
not
able to
I'm
hear us.
unable to hear anybody else.
No, he can't hear. Why not speak directly into your laptop?
That
He's
also
tried
he
that.
tried.
He tried.
Hello, am I audible?
Yes, you
You
are
are
audible.
audible.
Okay, thank you.
You can hear us?
Can you hear us? Can you hear us? Dr. Biswas, can you hear us?
I think so.
Is my screen visible?
Not yet.
So,
It is visible.
good evening, all. Today I'm
So can you
presenting
hear
the
us
case
now?
of Master X, 9 years, 3 months
Can
of
you
age,
hear us
resident
now?
of Merit, a student of 4th standard.
But Anindya, can you hear us? Can you hear us?
No.
Yeah, so I mean that will be difficult then, no, if he can't hear us.
Yeah, you cannot interact with him.
Yeah, you cannot interact.
Am I audible, sir?
Sir,
You are audible, but if you can't hear us, then
Vijay,
It
can you
makes
just give a call to him, sir? What are you waiting for, Vijay? Hello.
Sir, I have updated to join Biswas sir through mobile. I'll share the screen. So
yeah,
that
I think that
the
would be
computer is
better.
the problem.
Yeah, I think so.
Deepak is sharing that option.
Earlier we could hear him and
Yeah,
everything
yeah,
was. But now I
Yeah,
think-
we could hear him. Something.
I think he's getting reconnected now. Can you hear us, Dr. Biswas? Can you hear us? Now we cannot hear you.
Sir, please join through mobile, sir. We have sent link. Deepak Sharma has shared the link. Mobile use could join, sir. I'll share the PPT.
Can you hear us now, Anindya?
He's able to. Can you hear us, sir? But we are not able to hear him now.
Yeah. No.
Sir, I've just called him. He's joining through his mobile now.
So have we
Hello.
start? Yeah,
Hello,
now
am
we
I
can.
audible?
Yes, you are audible. What about us? Can you hear us?
Yeah, we can hear you.
Yeah, please go ahead, sir.
Perfect. Perfect.
Sir, I'll share the screen. You can share the next slide. Yeah. Can you make it full screen?
Hello. Yeah.
Yeah.
Thank you, sir. So good evening, all. Sorry for the technical glitch. And today I'm presenting the case of next slide, please. Master X, 9 years, 3 months of age, resident of Meerut, student of fourth standard, and the history was given by his parents, and he presented to the nephrology OPD in January 2023 with the chief complaints of fever 1 week ago, which was associated with nausea and vomiting, and for which he got reviewed by a local pediatrician and was evaluated, and he carried a urine routine microscopy report which was suggestive of microscopic hematuria. The next slide, please. So the history of present illness, he got detected to have a left small kidney in 2016 at the age of 2 years. So in December 2022, he developed fever, which was low grade, 99 to 100 degree Fahrenheit, without any periodicity, diurnal variation. It was associated with diffuse, mild abdominal discomfort and pain, nausea and vomiting for the same duration. There was no history of loose motion, dysuria, hematuria, strangury, frequency, or dribbling of urine. There was no loss of appetite or loss of weight recorded.
Just a minute, Dr. Anindya, just one small query. 2016, what happened? You didn't tell us that. No, how did he detect a left small kidney? What was the presentation at that time?
Sir, I have kept that history in the past history.
Oh, it's okay, all right, okay.
So at that point of time, evaluation revealed that he was NS1 antigen positive. The kidney function creatinine was 0.8, EGFR of 75.9 ml per minute, 1/1.73 meter square by Schwartz equation.
Dhananjay, I think your laptop is also because there is an echo.
Okay, sir. Sorry.
You can switch one of them off.
Or you can mute your laptop, so that's enough.
Yeah, mute your laptop.
Yeah, now I'm audible properly.
Better.
Yes.
Sir,
Yes.
sir. Thank you, sir. So at that point of time, his urine routine microscopy, the urine was turbid. There was trace albumin 32 to 34 per hyper frame. There was RBCs, and 4 to 6 WBCs were detected. There was no cast and crystals. The ultrasound abdomen at that point of time done showed a right kidney of 9.8 centimeter and left kidney of 5.6 centimeter. The right kidney appeared normal, and the left kidney had raised echogenicity with altered corticomedullary differentiation. So he was treated by his physician with medication, and subsequently he referred to the nephrology department in Max for further evaluation.
You didn't do culture?
The culture was not done, sir, at that point of time.
Okay, continue.
So in the past history, in 2016, at the age of 2 years, when first time he was treated by a pediatrician for acute periumbilical abdominal pain, and off and on episodes of fever, which was 100 degree Fahrenheit for the next 1.5 months. And at that point of time, evaluation revealed routine microscopy showed albumin 1+. No RBCs or WBCs were 1 to 2 per hyperfilm, and there were no cast and crystals. At that point of time, the culture was done and which showed no growth, and ultrasound abdomen showed a 8 centimeter right kidney and 5 centimeter left kidney with cortical thickness maintained, and CMD was also maintained in both the kidneys. His condition improved with the given treatment, and he remained well thereafter. Subsequently, in September 2020, he again developed high-grade fever, which was 104 with chills, but had no urinary symptoms, no pain abdomen. And at that point of time, evaluation revealed he was COVID-19 RT-PCR positive. The urine evaluation was within normal limits. The ultrasound abdomen showed again a small left kidney, which was informed to the parents by the pediatrician, and he again symptomatically improved with the given treatment. In the antenatal history, the mother had underwent her antenatal checkups and obstetric scans as medically advised and was not reported to have any fetal anomaly at that point of time. He was born full term, 9 months and 6 days, institution normal vaginal delivery. The birth weight was 3.2 kgs. He was completely vaccinated for all communicable diseases as per the schedule till date. Next. There's no history of renal disease, hypertension, diabetes in the family. Father and mother absolutely normal, and a younger sibling, brother of 6 years, who is also asymptomatic. There was no history of NSAIDs or other nephrotoxic medications that he has received. And other histories, there was no history of bedwetting, urinary incontinence, constipation. There was no history of delayed milestones or growth retardation recorded till age.
At what age did he develop? Did he acquire his toilet habits? No bedwetting is a little vague. No, I mean this is now. But when did he acquire his urinary continence?
By said 2 to 3 years. After 2 to 3 years, the mother said that there was no.
Yeah, so you mentioned that. Right.
Okay, sir.
Okay. 2 to 3 years. All right. Okay.
Sir. So to summarize, he's a 9-year-old boy without any significant birth history, completely vaccinated for his age, having left small kidney, diagnosed at the age of 2 years, presented with 3 episodes of febrile illness. First was query viral fever, second the COVID-19 infection, and third was dengue fever, and microscopic hematuria on urine evaluation. So on examination, he was average built. His height was 147 centimeters at this point. Weight was 40.50 kgs. A BMI of 18.74 kg per meter square. There was no pallor, no cyanosis, no icterus, no clubbing or edema. The blood pressure was 110 by 60 millimeter of mercury in sitting position in the left arm. The heart rate was 86 per minute, regular, and all the peripheral pulses were palpable.
Just tell us the percentiles also. You have shown it on the chart. Just read it out. What are the percentiles of height and weight?
It's above the 97 percentile, sir. So almost the weight is approximately around the 97 percentile for weight, and the
means
height
he's obese. He's obese, no? Then. And the height?
The height is, sir, again 97 percentile.
97 percentile. Okay.
Sir. So systemic examination, the abdomen appeared, the skin appeared normal. It was scaphoid. Umbilicus was not everted. Flanks were not full. It was soft to touch. There was no organomegaly, no renal angle tenderness. The bowel sounds were audible and normal. In the neurological examination, higher mental functions were normal. No deformity in the vertebral column noted. The cremasteric reflex and the bilateral ankle jerks were within normal limits.
Sorry, what was the BP and the percentile? The BP, the blood pressure, I missed it. 110. All right. Okay.
Sir.
Continue.
Next slide. And other systemic examinations were, say, within normal limits. Sir. So to summarize now, after examination, 9-year-old boy without any significant birth history, completely vaccinated for his age, average built with no growth failure, having left small kidney, diagnosed at the age of 2 years, 2 years of age, presented with 3 episodes of febrile illness, viral COVID-19 and dengue fever, no urinary infections, microscopic hematuria on urinary evaluation, and the clinical examination was non-corroborative.
Okay, fine.
So my probable diagnosis is Kakut, left hypoplastic kidney. Would like to rule out primary vesicoureteric reflux or secondary vesicoureteric reflux due to neurogenic bladder and spina bifida.
Okay, just hold on. But he came to you with fever, isn't it? You said he had fever for a week. And
no,
that is
sir,
after
it was a week ago, sir.
So he came to you only for hypoplastic kidney.
Yes, sir.
Yes,
It
sir.
was like documented in 2016 at the age of 2 years, and when he had fever a week ago, at that point of time, a urine examination was done, which showed 32 to 34 RBCs, and so he was referred by the pediatrician for further evaluation in the nephrology department.
Right, but he has never had any culture positive threat infection as per your
No, sir.
documentation.
No, sir. No, sir. No,
He
sir.
had some. He never had any UTIs in that sense.
Dr.
sir.
Bhowmik, your also laptop is on, I think, mobile and laptop.
No, sir.
Actually, your voice is echoing.
Okay, but no, I have not put on my
Okay, that's
mobile
fine.
at all.
There. Please go ahead. Yeah.
Okay,
So,
fine.
Sir.
So now tell us how do you investigate him? You said your diagnosis is primary viewer versus the secondary viewer. So what is your plan of action in this patient?
So next slide, please.
No. You can just tell what
Okay,
investigation will you ask for?
Yeah. So what are the investigations? Your plan of action?
So I would like to confirm that he is having a urinary infection or not. Secondly, there was microscopic hematuria reported. So would like to figure out again he's really having microscopic hematuria or not. So I would like to have a urine routine microscopy and a urine culture to find out that.
Dr. Anindya, can you tell us what are the pros and cons of urinary dipstick urinary examination versus microscopic examination? And how do you do a microscopic examination?
Sir, microscopic examination regarding, sir?
Urine routine, WBCs, how do you do it? And what are the pros and cons versus the dipstick, the multisticks?
So the dipsticks are used for proteinuria and the bedside proteinuria evaluations, and in microscopic examination.
No. Just hold on. See, what are the parameters which are done on a urinary dipstick apart from proteinuria?
Sir, blood can be detected in dipstick.
Yes, blood can be detected. What else?
Albumin can be detected.
Yes.
And bilirubin possibly. Sir.
No. From the viewpoint of infection, what can be done?
The
Dr.
viewpoint.
Biswas, there are 10 pads on the stick.
Have you used it ever, Dr. Biswas? I mean, do you use a 10 dipstick, which 10 strips, which Dr. Varma mentioned? Have you seen it? Have you used it?
Sir, I haven't used it.
You haven't used it. Fine. So it's very important that, in fact, when I sit in the OPD, even I've come here to the camp, I always carry this multi-sticks, which is 10 parameters. And the very important parameters which would be done in this case would be leukocyte esterase, all right, which will pick up the WBCs. And your nitrite test for bacteria.
Bacteria, sir.
Yes. So the leukocyte esterase test is very important because it can even pick up the lysed WBCs. So that's what I was asking. When you're doing a urine routine examination, if the sample is old, the WBCs may get lysed, and then you may not pick it up. So
yes,
in that scenario, your dipstick actually would be more sensitive. So you must use always, nephrologists at the point of care must use these multisticks. You can pick up WBCs as well as bacteria. Sir, how do you pick up bacteria? Any idea? Theoretically, you have not used it, but you should know the theory behind it. So bacteria convert nitrates to nitrites, and this is picked up by the dipstick. And this is very accurate, I'm telling you, because I work with it routinely. I go for camps regularly as well as in the OPDs. So you can easily pick up infection sitting in the OPD, right? So don't neglect that. So one is point of care test for urinary tract infection, and second is routine microscopy. So there it can be done either on a centrifuge sample or an uncentrifuged sample. So can you tell us the values for centrifuged and uncentrifuged, and how do you centrifuge the urine? Even that must be done by you in the exam. You are expected to do it.
Yeah, I think Dr. Biswas, this is a basic question. How do you do urine examination?
So the urine has to be collected. The clean catch has to be, midstream urine has to be collected
Yeah,
properly.
just a minute. For clean catch, I mean, what are the steps?
First is retraction of the prepuce, the clean the local the glands, and then ask the baby
Yes.
to
So for the male, it is you must retract the glands and clean the prepuputial area, and in the female, you clean the introitus.
labia. Yes,
Okay.
sir.
Yeah, but I was asking regarding my routine microscopy, centrifuged and uncentrifuged. How do you do that? We'll come to culture afterwards. So you must read up these things are extremely important. Okay. So you centrifuge it at 400 G for 5 minutes, then 10 ml of urine, you decant 9.5 ml, keep only the sediment, then resuspend it in another 0.5 ml, and then you check it under the microscope, and then you
Sir.
count. Or you do an uncentrifuged sample with a hemocytometer, you know, how we used to do the Newborn's chamber in our second MBBS days. And there, if you say 10 cells per cubic millimeter, that is significant. You know, so these basics, you know, you must know, and you must do it yourself as well. Okay.
Sir.
Okay. And so how do you collect culture here? Now coming to culture, how do you collect the culture? We said how you collect it. What are the other steps?
Other steps regarding, sir?
To collect a culture sample in a child.
Sir, in
So one
a
is a
child,
midstream. You can collect a
in a
midstream
child
sample if possible. What are the other types of samples which are collected in children?
suprapubic puncture can be done, and the
Yeah,
sample can
that suprapubic. Yes, and what is the cutoff for suprapubic?
Sir,
See, you know the
10 to the
cutoff for
10 to the
you know the cutoff for midstream, isn't it? I mean that everyone
yes, 10
knows.
to the power 5, 10 to the power 5.
Yeah, that is for your midstream.
Colony counts.
What
And
is
suprapubic? It is 10 to the power 2 to 10 to the power 3, sir.
not really? No. Suprapubic. If you're doing a suprapubic sterile aspiration, any amount of bacteria is taken as significant. And the value that you mentioned, that is for a catheterized sample. So you can collect it either midstream, or if it's a very small child, you can put a perineal bag for a female. It could be a catheter, or it could be a suprapubic puncture. So these are the 4 things which can be done to collect culture, and each of them have different cutoffs. So that you must know.
Yes, sir.
All right. So otherwise, you know, this is what happens. You don't have a culture report, right? So now carry on.
So,
Dr. Biswas, just for recapitulating, the patient only had hematuria, or there was pyuria also.
no, sir, it was not documented, sir.
So it is only hematuria on repeated examination.
No, sir, not repeated. Only the last examination that was done in December 2022. So at that point of time, he had this microscopic hematuria documented, for which he was referred.
Okay. Go ahead.
Okay, just hold on. Now tell us, I mean, since this patient basically has come with small left kidney, which has been diagnosed at the age of 2 years,
Yes.
what are your differentials?
So my differentials are a
Tell us your
hypoplastic,
differentials.
hypoplastic kidney, and
Okay.
sir, would like to rule out primary vesicular ureteric reflux.
Okay, antenatally, how do you diagnose reflux?
So antenatally, if the reflux is present, possibly the ureter will be visible, or there will be pelvic.
No. See, ureter antenatally will be difficult. No, we are talking of doing an antenatal scan in a mother. So there, which parameter do you look into? You don't. It's difficult to see ureter there. No, I mean, what will you see there?
The kidney size, sir.
You will see the kidneys. What else? How do you pick up reflux antenatally, or how do you suspect it?
So if the pelvis
One-
is dilated,
Yes.
Very good, very good. So
Yeah.
the pelvis is dilated. And what is the cutoff for the pelvic dilatation?
1 to 1.5
No. That is almost normal, isn't it? So more than 4 mm in the anterior posterior
diameter.
view. Yeah, and so more than 4. And if
More
it's
than
more than
4.
5, then it is probable reflux, and more than 10, it is grade 5 reflux. So it is the anterior posterior diameter of the pelvis that you look into. And so that would be called as a congenital reflux.
Yes,
So,
sir.
right. So, is there any sex predilection for congenital reflux?
Yes, sir. Boys do have commonly
Very good, very good. So males are much more likely to have a congenital reflux.
congenital reflux.
Yes, with a ratio of almost 3 to 1.
3:1.
And how does the ratio subsequently progress?
Uh,
So it is 3 to 1
ratio
at birth or
at birth.
antenatally. Afterwards,
After birth, sir, the females, they have
yes,
the
very
child.
good. So afterwards, it is the females who have more chances of getting a reflux, and by the age of about 2 years, ratio is almost equal. And
Equal
beyond 2 years, then it is more females,
in females.
right? And the other important thing is that it is this group of congenital reflux which is very bad because that is associated with hypoplastic kidneys,
Hypoplastic kidneys.
dysplastic kidneys.
Yes,
So
sir.
it is this males with congenital reflux and hypoplastic kidneys, dysplastic kidneys, which are very bad. And that's the whole controversy which Dr. Kher alluded to, that it is difficult to really say whether a reflux is a cause of CKD or not and whether it should be treated or not. We'll come to that later on. Okay, fine. So your one differential is hypoplastic kidney with, but you said the mother had normal ultrasound scans, isn't it?
Yes,
So I
sir.
hope, yes. So I hope they've done the fetal ultrasound properly. So maybe it was missed. I don't know. And it is a male child. Okay. Any other differential for hypoplastic kidney?
Sir, VUR, one possibility. Second is a neurogenic bladder with second because of posterior urethral valve and or spina bifida.
Possible. Second would be secondary reflux causing hypoplastic kidney on that side. In adult, of course, you would also consider renal artery stenosis, but in a child, I don't think that would really be that significant. Fine. So as I was saying, that first most important. Now coming to what Dr. P.P. Varma mentioned, that he had persistent RBCs in the urine without pyuria. Now tell me, what thoughts come into your mind? I mean, why do you think he would have such a condition?
So
We had
there
no
was no
culture at that
persistent
time.
RBC. So only one report of urine routine microscopy reported RBC. So it was not persistent RBC. The initial urine routine microscopy done during his illnesses, two illnesses, the urine routine microscopy was reported to be fairly within normal limits, sir. So
Okay, fine. So one presumption could be that at that point of time, the urine was turbid and he had RBCs, but WBCs was less. It could be UTI still, but of course, we don't have a culture report at that point of
yes,
time.
sir. Yes, sir.
Okay, continue.
So I would like to now confirm my the second possibility of VUR. So
Right.
so the gold standard. So the
That
gold
shows that's
standard.
right. This is his current investigation that you're
Yes, sir.
showing.
This is the current investigation we did, and
Urine is completely normal.
normal, sir.
Okay, fine. Continue.
So would like to confirm the second possibility of
No, what
VUR.
was the ultrasound finding? Do you do ultrasound also if you suspect reflux?
Sir, it is done, but as he had ultrasound before reaching this hospital, so we did not do any further ultrasound at our hospital.
What do
So
you
I have
expect in
mentioned.
ultrasound?
So in reflux, sir, there can be dilatation of the ureter, the dilatation of the pelvis can be seen.
What else?
As pelvic
So one is
calyces,
dilatation. What else?
tortuosity can be seen, sir, as well as
Anything else?
What do you see for nephropathy? See, you look for evidence for renal damage. So how do you
renal
look for
damage,
evidence of renal damage?
sir, the size of the kidney and the corticomedullary differentiation, sir.
So that is for diffuse. But if you are suspecting reflux,
So any cortical defect is there or not? So
Yes. So you can suspect scars also on ultrasound.
yes, sir.
where do you suspect? Where do you look for scars?
So at the poles, sir.
Why?
The
Why?
apparent-
Why?
So because the poles, they have commonly they have the refluxing papillae. So the chance of
What are they
reflux-
called? What are these papillae called? Yeah, you're right. You're right. They are refluxing papillae, but what
are
is the
they
anatomic
called?
structure and what are they called?
And
exact
their
name,
shape
sir.
also. What is their shape?
What is a normal papilla? What is a normal papilla? Can you describe a normal papilla?
So it's a conical shaped. The papilla
Very
is
good.
conical
Yeah.
shaped with a, and they have and the refluxing papilla, they have a they don't they are not conical. They have a broad say apex with cribiform.
No,
Like
not a broad apex. They're concave. They're concave, and they're
concave.
called compound. And they're called
Yeah.
compound papillae. They're called compound
Oh, compound
papillae.
papilla. Okay, sir.
Yeah, with wide.
Normally, you have got
reflexes.
convex papillae, and these
Yes.
refluxing one are compound or concave.
Concave.
And they are mainly found at the poles.
Poles.
That's the reason why. And the other thing which was earlier thought was the water hammer effect, but that is probably not right. So what is actually correct is the type of papillae. So compound papillae, which are concave and have wide orifices. That leads
Yes.
to
That leads to reflux of urine into the duct, and which causes
so that is called intrarenal reflux.
reflux.
Okay? Intrarenal reflux.
Yes, sir.
Dr. Biswas, how many papilla are there in each kidney?
So how many papilla?
Yeah, in
Can you
each kidney.
just make a rough guess?
Number of papilla?
4 to 5, sir.
No, 4 to 5 नहीं है, ज्यादा है.
थोड़ा कम हो गया ना?
Make it double.
3 calyx. So how many papillas are there in the combined 3 calyx?
6. So I didn't get the question, sir.
How many papilla in each calyx? He is giving you a hint. But you don't know the. About 9 to 10 papilla in each kidney. So you have. Can you tell me any other animal which has this kind of papilla? Human like papilla? Pigs. Yeah. So how did you know this?
Sir, I have read about this transplant of pig kidney, xenotransplant. Xenotransplant.
So is that the only reason why pigs were selected as any other reason why you think pig is selected as an organ donor for humans? Any other? One could be this, that any other animal which has multiple papillae? How many papillae does usually other mammals have?
1 to 2, sir.
Yeah, usually one or the. So there are not many animals which have multiple papillae, and pig is one such animal which has multiple papillae. But I think the reason for choosing big organs is basically that the size of the organs, especially the heart and the kidneys and the liver, look about the size of the human heart, human kidney, and all that. So that's the reason why they've been chosen to be probably the best donors for organs, if at all it happens ever. So that's where they are. They're trying to humanize the pigs. Anyway, we digressed, and I thought,
Yeah, okay.
yeah, pigs
Okay,
are being used as the animal experiments for studying the reflux nephropathy, and they've been the animals because these papillae are exactly like the humans, and that's why this has been studied. Very extensive studies in animals, especially the pigs, for reflux nephropathy.
Sir, okay, sir.
Okay.
And
Okay,
when
so
you
coming
talk
down,
of hypoplastic kidney, Biswas, how many
Yes, sir.
papillae are there in the hypoplastic kidney?
Sir, in the hypoplastic kidney, it is only the size is less with normal decreased number of normal nephrons. So possibly it will be almost.
Okay.
Don't
Go ahead.
exactly remember, sir.
Go ahead. I thought there are less than 6 papillae in the hypoplastic kidney, but I stand. What do the examiners say? I don't
sir,
know.
if it is a dysplastic kidney, then there will be less.
Yeah.
With dysplasia, then hypoplastic dysplastic kidney, then it will be less. Otherwise, maybe it will be the same. Okay, now to Anindya, just coming down, we talked of the papillae upstairs. Reflux, if you're thinking of, what is the other characteristic of the ureteric orifices in the where it implants into the bladder in patient who has reflux? Is there
So
any
the ureteric,
special?
yes, sir. There's part of the ureter that is submucosal in the bladder, and it opens in the bladder in an oblique fashion.
Right.
So that is
So
the
what is the normal length, intramural length of the ureter?
1 to 2 centimeters, sir.
No,
Good.
no.
Yes.
You,
It's
you,
about
you,
one centimeter.
you
1.3
have to give
centimeters.
in comparison to the diameter of
Right.
ureter.
I was coming to that.
Usually it is 5 times the
Yes,
diameter of ureter.
it should be
Sir.
5 times. Yeah, it should be 5 times. But it has been seen that infants it is about 0.5, then it increases with age to about 1.3, and it should be 5 times. That's very important. It should be 5 times. What else? So how does it look like if you do a cystoscopy? I mean, is there a special look to this ureteric orifices?
Golf hole.
They're called golf hole, right? So why is it golf hole? And where are they? The position, is there any
The
change?
upper part of the trigone, sir, it opens in the.
Yeah, so the opening is more perpendicular. Okay, it's perpendicular. So I mean, you have a golf hole, and these orifices are more laterally placed. Okay, they are more laterally placed, and they're perpendicular. So you have the golf hole ureteric orifices. Okay, fine. Now carry on.
So would like to confirm confirm VUR. So although the gold standard is voiding cystourethropy, but we did a DRCG examination, and we found that there's a reflux as indicated by the red arrow when there was a full bladder in the left side.
Okay, now tell me, I mean, DRCG versus your conventional MCUG, mixed cystourethropy, how is it better or worse? Compare the two.
Sir, in DRCG is a one-time short procedure with a small radiation exposure. Here,
Yes.
the DRCG requires a radioisotope, and
Yes.
it is a short procedure and can be done easily.
But what are
And
the limitations? What are the limitations of DRCG?
Yeah, the limitations of DRCG are like we cannot define the anatomy in detail, sir. We cannot grade the reflux.
You cannot grade. Who has graded the reflux?
Sir, this International Reflux Society and study, they graded the reflux into 5 categories, sir.
Yeah, so I'm sure you know them. I'm sure you know them. So what is
They used this grading system, but it wasn't devised by International Reflux Study Group. It was devised by somebody else. It was a Urological Society, American Urological Society classification or grading.
So what is grade 2 reflux?
So grade 2 reflux is the urine reaches up to the pelvis, but the pelvis is not dilated, sir.
Right. So, I mean, it almost looks like a normal IVP. This is what I always teach my students, that grade 2 reflux almost looks like an intravenous pyelogram, which you don't do nowadays. We do a CT urogram, of course. Okay, fine.
So in
what else? What is the other limitation? What are other grades of reflux?
So grade 2 is the urine reaches the pelvis, but the pelvic dilatation is not there. Grade 3, there is some amount of calyceal say blunting, and grade 4, there is dilatation.
Yeah, before blunting, there's mild dilatation of the ureter and peritoneal system with very minimal blunting, if at all. Grade 3.
Yes, sir. And in grade 4, there is the grade 4, there is dilatation of the ureter and the pelvis and clubbing of the calyces. And in grade 5, there is tortuosity of the entire urinary tract with dilatation of the pelvis and clubbing with hydronephrosis, sir.
Right. So this is one limitation of DRCG. Now, what is the other limitation? Any other limitation of DRCG?
So exposure to radioisotope?
No, but
no, I'm asking limitation. I'm asking limitation. I mean, how is it at a disadvantage compared to your MCUG? One is it cannot grade the reflux accurately. It can only tell you roughly, moderate versus severe.
Give the
what
anatomy.
Else?
It cannot give the anatomy of the urinary tract, sir.
Very good. So you will not be able to diagnose any other urinary tract abnormality, whether it's duplex ureters or whether it's a urethral abnormality. So these are the two important limitations of DRCG. Okay. So now tell me, what has been the change in the diagnostic approach to a child who has urinary tract infection and fever over the last few years? Has there been a change?
Urinary tract
While investigating a child who presents with a febrile UTI, has there been a change in the guidelines by the various societies, and why? See, you did a DRCG, in lieu of MCUG. So, but is there a slight change, and why is that so? See, the change is this, that it has been found that diagnosing reflux, I'll come to that afterwards, is not always of much benefit. So, I mean, doing an invasive procedure like gold standard MCUG is not really justified. So now you have the top-down approach. So the American Society now advises the top-down approach, which means that when a child gets an UTI, you can avoid doing these invasive procedures initially and directly first do a DMSA scan. Okay, so to pick up any scar. So this is called as a top-down approach. But of course, I mean, it is nothing hard and fast. And that is because it has been found that exposing a patient to radiation and is really may not really be that worth it. Tell me, what's the natural course of a reflux?
Dr. Bhowmik, let me just clarify here one thing. See, Dr. Biswas, we have discussed that the one way of presentation is like antenatal diagnosis or suspicion of reflux, where you
Yes, sir.
find dilatation of the pelvis.
Yes, sir.
Postnatally, you investigate these infants and confirm whether they have reflux or no reflux. What is
Yes,
the another method of presentation by most of the other kids? How are they diagnosed with reflux?
So they present postnatally with frequent urinary tract infections, and when reflux is suspected and it is found that hello.
Yeah, go ahead.
So, and in postnatal urinary tract infections, when it has been found that majority of them they had reflux, when evaluated, found that majority of them had
how
reflux.
many would have reflux? Say there are 100 children or less than 5 years who develop febrile urinary tract infection or febrile illness, and you do a MCU in these children. So how many do you think would have a reflux?
So approximately, sir, 50% chances are there to have a reflux. We can.
Yeah, so up to 50. So maybe 30 to 50% of these children may have a reflux, right?
Yes. Yes,
but
sir.
Then there are disadvantage of doing MCU.
Yes,
so
sir.
it is associated with high amount of radiation
exposure and
plus
chance
the risk of introducing infection when you do a catheterization and you do a MCU. And that's
sir.
why what Dr. Bhowmik was alluding to, that you don't go ahead and directly do an MCU. You look for a scar, and if you find a scar on the MSA scan, then you go back and look for a reflux. So maybe you can avoid doing MCU in some of these children, where
Yes,
just
sir.
picking up a reflux will not help in their management.
Yes,
right?
Sir.
Yeah. Over to you, Dr. Bhowmik.
Yeah, no, fine. So I think you raised this very important issue of presentation of reflux. One was antenatal ultrasound scans in the mother. Second was this UTIs. Just complete presentation of a viewer. I mean, from childhood to adulthood. What are the other presentations? How do you diagnose reflux? So for 1 and 2 we have discussed. So first is antenatal. Second is UTIs, febrile UTIs. What are the other presentations?
So they can present with. Sorry, sir.
So when do you suspect? Otherwise,
when do you suspect?
In addition to these two scenarios,
Recurrent febrile illnesses and
that we discussed.
That is the second we have discussed.
That is already done. What else? Anything else? Okay, I'll give you a clue. I mean, if a child has a viewer, what are the chances that a sibling will have viewer?
There is high chance to have a sibling.
Yeah, high means how much? High means how much?
Say 80% chances, sir.
No, about 25 to 30%. 20 to 30%. But then that is worth doing a study in the sibling. That's what I was coming to. So another presentation of a reflux, suspecting a reflux, is if a sibling has a reflux,
you
check it in the other sibling. Yeah, so that is viewer in the sibling. Now coming to adulthood, how do you suspect reflux?
How do I suspect reflux? The normal presentation of a reflux is there are in urinary tract infection, recurrent urinary tract.
That we have done. See, listen, don't keep repeating that. We have already discussed. No, what else?
There can be bowel bladder dysfunction. There can be bowel bladder dysfunction, sir. As well as
there could be bowel bladder dysfunction. What else?
Failure to thrive.
Yeah, that is all a part of infection.
Of recurrent infection.
That is infection. Anything else? See, the other important thing is in children, if you have calculi, that is one indication. Then UTI in pregnancy, one should suspect reflux. And more important for us, very important that we see daily in our OPD is young hypertension. Please, it's very important. In fact, there are studies from even our institute, So in young hypertensive, reflux is a very important differential diagnosis. And you do pick up reflux in a significant percentage. The percentage varies from different person to different person. And then, of course, ultimately, I mean, sometimes they can have proteinuria. They can even have nephrotic range. Can they have nephrotic range proteinuria? Can reflux have nephrotic range proteinuria? Because reflux is basically a tuberointerstitial disease, which has subnephrotic proteinuria. But in which condition of reflux you will have nephrotic range proteinuria?
A grade 5 reflux, sir?
Why would they have nephrotic vein proteinuria?
I mean, see, nephrotic vein proteinuria means there is some glomerular damage. No, otherwise you will not have nephrotic vein proteinuria. So which
Yes, sir.
glomerular disease occurs with reflux?
Don't know, sir.
FSGS. Huh? So
Yeah,
focal segment glomerulosclerosis,
yes,
FSGS can occur.
focal segment
So
glomerulus.
yeah, so that could be another presentation. And last, as Dr. Kher mentioned right in the beginning, is CKD, right?
CKD.
So yeah, it should be CKD even going on to ESRD. And that is why, I mean, I'm just talking retrospectively, that is why, at least in our institute, we do MCUs for all pre-transplant patients, so that you don't miss the diagnosis. So these would be various conditions where you would suspect reflux, so it's not only just recurrent UTIs, right? So please remember these 7-8 indications for suspecting reflux and doing the investigation. Right.
Dr. Biswas, what is the natural course of a childhood reflux? A young child who had reflux. So what happens to these?
Sir, ideally,
reflux?
Sir, ideally 80% reflux resolves spontaneously by the age of 2 to 3 years. That is the low grade reflux. But if there is high grade reflux, then they take a little longer time and may resolve by around, say, 9 to 10 years of age. So spontaneously.
Or they
Right,
may
so-
not resolve at all.
Sir?
Some may not resolve.
Not
A
resolve.
Some may
portion
not
of high-grade reflux will resolve finally.
resolve. But some of the high grade reflux, they may not resolve at all, to the tune of approximately around 30%, 30 to 40%, they do not resolve.
Yeah, so which are the other clinical pointers that they may not resolve? In fact, there's something like a viewer index also someone has made. So one is the grade of reflux, of course, and then the common sense. I mean, like if the patient has any other bowel bladder abnormalities, if they have any other ureteric abnormality, so these people will not resolve.
Unilateral or
The
bilateral?
second,
So it's more likely that the unilateral reflux will resolve. If the
Resolve.
reflux is bilateral, the chances of resolving it spontaneously will be less.
Less.
Great associated urinary abnormalities. So if they have other urinary abnormalities, the chances of spontaneous resolution is less. And fourth is bladder bowel involvement. So if they have associated bladder and bowel abnormality, then again the chances of recovery is less.
Yes, sir.
so what do you know about this bladder bowel abnormality? What is it called? Is there any other term? Dysfunctional elimination syndrome. Okay, so I mean, because they both come from the cloaca, both the ureter as well as your anus. So what are the other manifestations of this BBD or DES?
Constipation.
Very good. So constipation is very important. But coming to bladder first, bladder, what are the other manifestations of BBD? From children.
The enuresis, bedwetting, prolonging.
Yeah, in a child who has acquired control of the bladder, if subsequently develops enuresis at night or daytime enuresis. Okay, so that is one. What else?
Daytime enuresis, then the incontinence will be there.
Incontinence. Then hesitancy, frequency, if the frequency is more or if it's very less, or if the stream is not good, if the staccato stream. So these are all bladder abnormalities.
Yes, sir.
These are the children who will have some psychological overlay. They will tend to hold their urine for long, urge incontinency. They will take long to pass urine.
Yes, sir.
And obviously loss of control in holding. And same way, they are also habitual constipator. Right? So these are the indicators. Their posture will indicate whether this child is having associated bladder bowel incontinence. So they're very particular postures. They'll keep their leg tight. as if they are holding their urine.
Yes, sir.
What is that sign called? There is a name to it also, some Vincent's sign. They keep their legs crossed, and
Okay, sir.
right. So that's why you must, in all these patients, take detailed history of the bladder bowel problems as well. Okay. Okay, continue. So you did a DRC in this patient, and then what did you find, doctor?
Biswas.
Yes,
Dr.
sir.
Biswas, continue.
So then we did a DMSA scan to see there's any cortical defect present in the other kidney or not, and we found that as of now the right kidney appears to be having no focal cortical defects, sir.
Sorry, just a minute. So the right kidney was normal.
Yes, sir. The right kidney was normal.
Okay, can you tell me for DMSA scan in acute pyelonephritis, what does it look like, and how is it different from if a patient has scar? So how does a DMSA scan look like in acute pyelonephritis?
Sir, in acute pyelonephritis, the area that is involved will have decreased uptake of the radio tracer, and
Good.
And subsequently when it
No,
there's
so how is it? Why is it not scar? You get my question?
Yes, sir.
Why is it not a scar?
There will be decreased uptake in that area, but when it develops a scar, then there will be a defect in the outline that can be visualized. That is,
very good. So in acute pyelonephritis, there is a focal or diffuse reduction in the uptake of the radionuclide, but the contour is normal and there is no cortical thinning, right? So I mean that's how it differs from a scar.
Yes, sir.
Okay. And what are the types of doing a DMSA? Have you heard of types of DMSA?
Types of DMSA, sir.
Yeah, why I'm saying is because it has some relevance. One is a planar way of doing it, and another is a SPECT.
Okay, sir.
So SPECT. So our institute, we are doing the planar. Okay, so planar. And which views do you take on a DMSA scan? Which views?
Anterior, posterior, and oblique views.
Very good. So posterior is the standard, posterior, oblique, and
posterior.
sometimes anterior as well. And how is this radionuclide different from a DTPA?
So it is that's a technetium. The radio tracer is a technetium, and this is Markov.
Which is a dynamic scan, and which is a dynamic scan, and which is a static scan out of these two?
So the dynamic scan is a DTPA, and
yeah. So tell me, why is this a static scan? I mean, what is the physiology of using DMSA?
Between DTPA and DMSA.
So it is taken up. It is taken up by the kidney, and while in the excretory phase, it is taken. It is absorbed by
taken up by what? The DMSA or the pentasuccinic acid is taken up by whom?
Tubules, sir. Tubules.
Which part of tubule?
The proximal part of the tubule.
Yeah.
So it defines the parenchyma. It's like
so. The DTPA is like inulin. It is freely filtered and completely excreted, okay, without any retention in the parenchyma. Whereas the DMSA gets concentrated in the parenchyma. So that is the difference. So there is a time difference as well. So DMSA scan, when do you take the films?
2.5 hours after the.
Yeah, that's written. It's written there. Yeah, so about 2.5 to 3 hours later. It's taken about 2.5 to 3 hours later. Right. So your DMSA showed normal right side and very poorly functioning left side. Okay,
Yes, sir.
Go ahead.
go ahead.
So next slide, please. So my diagnosis is with all the above findings and the evaluation, it's acute left atrophic kidney, hypodysplastic with left primary VUR and reflux.
Yeah, but you could not grade the reflux, no, because you did not do an MCUG, so you have not graded the reflux.
Yes, sir.
Right. And why do you call it congenital type?
Sir, this is the type that is common in boys. First is second. This is the variety in which and it does not require any urinary infection. It is not because of the urinary infection that recurrent urinary infection that there is kidney damage or nephropathy due to primary VUR. So
This patient, in fact, did not have a definite urinary tract infection. So, right, the first infection at the age of 2 years was suspected to be UTI, but clinically, whatever investigation he showed did not support that he had UTI even at that point of time. But he had a small kidney. So apparently the first febrile illness, he already have a small left kidney.
Right. Okay, fine. So when you diagnose UTI in and reflux in children, what is the current management?
So the management is lies on 3 parameters, like we have surgical management, we have medical management, or we can wait and watch because
yeah, you have told it a lot topsy-turvy, you know. So first is you first start with the wait and watch, then the medical, then surgical. All right.
Surgical. Sir, so
yeah. So medical, what is the medical management?
Sir, in the medical management, the prophylactic antibiotics again the need can be given. Prophylactic antibiotics can be given.
So which antibiotics are given and in what dose?
So prophylactic antibiotics like trimethoprim sulfamethoxazole or ampicillin cephalexin can be given, and the trimethoprim sulfamethoxazole it can be given as trimethoprim of 2 milligram per kg body weight,
okay.
and
yes,
at 10 milligram per kg body weight, and ampicillin.
So in whom do you give cephalexin and whom do you give trimethoprim? Is there any recommendations or guidelines? See, it is in infants, cephalexin is preferred, whereas in the post-infancy, it is trimethoprim which is given. And which is the third one? Amoxicillin is usually not given. Amoxicillin is not given. Which is the third one? Nitrofurantoin. Nitrofurantoin can be given.
Nitrofurantoin.
What dose?
So 1 to 2 milligram per kg body weight.
Yeah, that is also 1 to 2 milligram per kilo. That's right. And how long?
Sir, it can be given up to the age of 5 years, 2 to 5 years, sir. And
right. So the Indian Society of Pediatrics, they have come up with the detailed table, I mean, in which group, how much is to be given. Now, you tell me, what is the controversy regarding giving these antibodies and which are the landmark trials in this regard?
Sir, the landmark trials, one is the RIVER trial that has evaluated the prophylactic antibiotics versus placebo in.
So how many children they had?
So they had.
How many children?
They had 567.
607. 607. They're
Yes, sir.
600. And what are the other baseline characteristic which may have some relevance in our discussion?
Uh,
Majority were
majority
females.
majority of them were
Majority
females.
of them females, and they're all
Females.
low risk group. It was a low risk group mainly.
Low risk group, yes, sir.
It was a
Up
low
to
risk.
the age of 6 years.
It was a low risk
2 to
group
6
in
years.
females. And what did they find?
They found no benefit.
No, first tell me
although they
what
prevented,
no
they
no
prevented,
benefit.
What was their outcome?
What was the positive? What was the positive finding?
sir, they prophylactic antibiotics prevented the recurrent UTI episodes in the antibiotic group, but they could not say prevent the formation of new scar or progression of the scars and the progression of renal parenchymal defects.
So it did not prevent scar formation, and this is a very important finding. But a subgroup analysis was done, which came out subsequently, which showed that in patients with BBD, probably it could be more useful. We had an AIIMS study as well, so I'll just mention from our pediatric nephrologists, in which actually they had almost equal males and females, and I think no BBDs. And in this group, it helped neither in preventing recurrent febrile UTI nor in scar formation. So it didn't do anything. So that is the biggest controversy of giving prophylactic antibiotics. Yeah.
So you said you will give antibiotics for 3 to 5 years, or 3 to 5 years of age.
3 to 5 years of age, sir.
Why?
So because after 5 years of age, the chance of scar formation or say recurrent UTI reduces, because majority of the refluxing papillae may grow and convert into non-refluxing papillae. So chances of intrarenal reflux reduces by that age.
Yeah, so there is no definite recommendation, but that's what is the assumption. So either the reflux resolve by this time, even if the reflux persists, the refluxing papilla turn into non-refluxing papilla, the chances of intrarenal reflux is less and the scar formation is less. Unless they tend to have repeated pyelonephritis and infection, which may cause scarring of papilla and will prevent them to become non-refluxing. So they continue to be refluxing papilla. So in these children who have a recurrent urinary tract infection, you look for other options. So either you continue antibiotic or you do a surgical correction so that they do not get recurrent infection. Okay, go ahead.
Yeah, so what is the other treatment?
Surgical correction, sir. And
before surgery? Yeah, okay, surgical, what surgery you want to do?
Sir, reimplantation of the ureter.
Before that, is there anything else which can be done? Anything less invasive?
In endoscopic submucosal injection can cystoscopically can be given.
Cystoscopic injection. What is injected?
Sir.
Right. So it is initially it was Teflon, the polytetrafluoroethylene, PTFE, and now mainly it is your deflux, which is a copolymer of hyaluronic acid and some textranomer. So it is that. So now it is mainly deflux which is injected. And again there are two methods in it. I was just seeing on sting and hit. So one is totally subureteric and one is intraluminally creating a hump there, which has its own advantage. So you must know about this endoscopic procedures. And surgery?
Surgery, sir, it is reimplantation of the ureter, either open or laparoscopic. By two methods it can be done.
Right, either open, and then again there are 2-3 methods. We need not go into that. So at least there are 3 different methods. And any further advance beyond that?
Sorry,
So
sir, I
now
didn't get you, sir.
any further advance in surgery?
In addition to laparoscope, what else can they use? Something better than laparoscope.
Robots.
Yeah.
Yeah. So now the age of robots. So I mean, robotic surgery is they are saying could be very good, but then it has a very steep learning curve, and it is of course very costly and not accessible everywhere. So these would be the various methods. Now, just coming back now, we'll just go back. So what is the controversy? I mean, why it may or may not be really worth diagnosing VUR immediately after UTI? So one is that, you mentioned that the majority would resolve, isn't it?
Yes, sir.
Majority resolve. So
Yes.
whether it's worth doing all these invasive tests, that is questionable. Second, as your case very nicely demonstrated, I think it's a beautiful case that this patient developed scarring without any obvious infection, isn't
Yes,
it?
sir.
So I mean, yeah. So I mean, even without infection, you could develop scarring, and
Yes, sir.
then you see, no treatment modality has shown that you can reduce scarring. All the RCTs are negative, isn't it?
Yes, sir.
All RCTs are negative. So data is
Yes, sir.
not really robust regarding that VUR and scarring and CKD is useful. So there are 3-4 reasons why there is so much controversy, and that's why you like to avoid invasive investigations as much as possible. And maybe if you have facility for a DMSA, you could go ahead and do a DMSA for your planning your further management.
The other reason
yes.
is like most of the studies which you are mentioning, like International Reflux Study Group, which compared surgery versus medical treatment, or the other River study, which has compared placebo versus antibiotic. Their selection criteria was the second criteria which we have discussed. Mainly women, 90% girls who were diagnosed to have vesiculoureteric reflux after an episode of fever, febrile urinary tract infection, right? Around 2/3 of these girls already had a scar when they were diagnosed with reflux. So 65% already had a scar when the first time they were diagnosed as reflux. And probably that is the reason whatever you do subsequently will not prevent the progression of these.
Progression of the. Yes, sir. Yes, sir.
So in this case, do you think surgery is going to benefit him?
Well, sir, with the DMSK scan that we have done, we found that the right kidney appears as of now within normal limits without any focal cortical deficit, but left kidney is atrophic, and so doing a surgery, I don't think so will be able to save his left kidney, because we have documented a high-grade VUR in the left side only on the DRCG scan. So doing a surgery in this case as of now will not be able to save his left kidney, as it is already atrophic. So it's not indicated as of now for him.
Any antibiotic prophylaxis? Will you put him on antibiotic prophylaxis?
Well, sir, whatever the data available is, again, says prophylactic antibiotic cannot prevent the progression of the renal parenchymal defect or prevent the new scar formation. So, and
Biswas, your patient hasn't had a single episode of urinary tract infection in 9 years.
Yes, sir.
Why are you quoting? So he hasn't had even a single documented urinary tract infection in 9 years. So I don't think there would be any reason to prevent what. So, and then you are saying that you would give antibiotics predominantly, maybe 5 years. Some people might say 10 years. He's already nearing about 9 years. So why would you give prophylaxis to such a patient, sir?
I'm not giving prophylaxis. I said ki.
No, I'm saying you were giving studies and so showing. In this patient, there is no documented evidence.
Evidence of any urine.
Never had urinary tract infection at all. So tell me now one question. You have an adult whom you are taking for transplant. Dr. Bhowmik was saying that they do MCU. Every unit may not be doing it, but you find that there is reflux in this patient. Maybe
Yes, sir.
grade 4 reflux. He doesn't give you any history of urinary tract infections. Like this patient, he is now for transplant. A 20-year-old kid, and he is for transplant. So what will you do? You will do surgery on him for reflux, take away the kidneys, do a nephrectomy. He has bilateral grade 4 reflux, no history of urinary tract infection. So you will go ahead and do the transplant, or you will, and there is no bladder deformity. The bladder function is good.
So we can go ahead for the transplant, sir,
Yeah,
without taking out the kidneys.
yeah. So that's why many units, unless you have significant urinary complaints, or there is some past history of urinary tract obstruction or urinary tract infections or anything. Otherwise, in patients, most of the patients, if there are no urinary abnormalities, many units, including ours, we do not do regular MCU in these patients. And the reasons have been discussed by Dr. Bhowmik himself. And we don't do it. And we have fairly large experience of these transplants, and they've done very well. So we do not do a routine
MCU.
look out for an MCU in a pre-transplant situation.
Yeah,
I'm sure
Dr.
there are.
Dr. Kher, I'll just give a few clarifications. I fully agree with what you have said, and even we would not do nephrectomy routinely in these patients unless they've had recurrent UTI. Why we do it at all? Of course, that is the question. One is, of course, we like to have a proper diagnosis so that we know what is the basic kidney disease, which is worth knowing. Otherwise, I feel that often this CKDU thing is very much overdiagnosed. And then it tells us, that if a patient has reflux, he may have more chances of post-transplant UTI, and then we can be more careful and treat accordingly. In fact, in one of our very recent patients, just last month, we did a post-transplant bilateral nephrectomy in a patient, who was having recurrent UTIs, and we had to go ahead. So but I fully agree that you need not do routinely pre-transplant in all patients, but that's the reason why we are doing it.
Okay,
Dr. Bhowmik, does this case very clearly shows that without infection also,
yes,
high pressure, one can develop scars.
You can, yes.
Which this patient has clearly developed. Just for the sake of completion, last question, Dr. Biswas. What is the GFR at birth, and at what time GFR becomes normal? And what is the kidney size at birth, and when it becomes normal?
So the kidney size at birth.
This child came to you at the age of 2 years. What is the expected kidney size at the age of 2 years, and what was his size?
So his right kidney was 8.5 centimeter at 2 years, and it was 5.6 centimeters on the left side.
What size do you expect?
So, sir, it should be around 9 centimeter.
No, at the age of up to 5 years, the size is 3 inches. That is 7.2, 7.3 centimeters. That is the size mentioned. What is the GFR at birth? And when does the GFR become normal, adult time?
Sir.
GFR at birth is low. It is 40 to 60 ml. And by the age of 2 years,
it's low, it's
normal, 120 ml. This, you should just know that. I think I personally thought that it is a very small topic and we will finish it in 40 minutes. But I think Dr. Bhowmik and...
no, actually, I had a lot of other things. The post-transplant reflux also, I think. But anyway, we can...
I think in the post-transplant cases, have reflux. Dr. Biswas? In the post-transplant cases, if you do whatever the test you are mentioned, whether radionuclide or MCU, do you find reflux?
What percentage do you find reflux? What percentage?
Sir,
anyway,
almost.
It's in very large number of cases, over 70%. Once we did I don't say a correct thing, but we did a study, we did MCUs in these patients. Over 70% had reflux of some degree, but the whatever classification, the American urology classification of reflux is, it is not valid for transplant patients. It is valid only for native kidneys. Is that right, Dr. Bhowmik?
Yes, that's right. And of course, it will depend mainly on the surgeon's expertise. And I don't want to criticize anyone, but then urologists versus general surgeons, when they do the surgery, I mean, there is a difference. Urologists make a very good submucosal tunnel, and it is much less. In fact, I was just seeing that it's from 0.5% to 86%. You see the wide range. So in our own institute, we don't have urologists. We have got general surgeons, and I think we have a very, very high percentage of reflux in our patients.
Yeah. So I think last minute comments by Dr. Singhal.
Biswas, I think one point which I wanted, you didn't tell me about the 24 hours urine protein in this patient, or urine protein creatinine ratio.
It was not done, sir. The creatinine at 2 times that was evaluated. That was one was at 2 years of age. It was 0.4, and at in December when he had this fever,
I would totally disagree with you that if you have a normal creatinine, you will not look for albumin in the urine or proteinuria in the urine. It is a damage marker, and for even classifying CKD,
yes, sir.
One is GFR, the other important component. And I'm actually pained that this I see very commonly in practice. I find urine routine examination not showing albumin. People do not do urine protein creatinine ratios. Urine is a neglected test in the lab. It is a neglected test by the nephrologists as well as physicians. Nobody wants to do it. In the lab, it is kept as the last thing that may be done. I don't know whether it is done or not done, but you should always do. Every patient of kidney disease must have a urine albumin creatinine ratios. And I think it's an important component of treatment for this disease. If you want to prevent progression of kidney disease,
yes, sir,
urine protein, that would be the one of the markers by which you will show not only for progression of kidney disease, his mortality, his survival, for his ESRD, every aspect of kidney disease. So urine albumin creatinine ratios or urine protein estimation, important.
Yes,
so irrespective of whether the GFR is okay or GFR is not.
Yeah, that is a message, Dr. Biswas, and I'll suggest you should do few urine examinations.
One last comment. One last comment. You see, I've come to this camp and I'm carrying these multi-sticks. I do it bedside as well as point of care in OPDs and camps. It's very important test.
Extremely important.
Yes.
Extremely important test.
So you must know whatever are the 10 regents and whatever what test can be done. What is tetrabromphenol or whatever. You must know them. That you can do bile salts, you can do uroglobulin, urobilinogen, all the 10 tests you should be aware of. And you must test the urine yourself. You must centrifuge it, test it, see it under microscope couple of times.
I'm surprised that I'm surprised Manoj hasn't sent him to the lab.
Yes.
So tomorrow, first thing he should do is go to the lab.
Dr. Kher knows. In PGI, we had to do urine examination of all patients, all hospitalized patients in the ward ourselves. We used to carry test tube ourselves for all patients and do it. You must do for few patients.
I'm sure Manoj has done this during his training as well.
And if I think if there are not any last minute comments, I must thank Professor Bhowmik and Professor Singhal for a very lively discussion and very practical discussion. The topic, I must thank Professor Bhowmik. He's sitting in Karnataka in some Tibetan camp, and he took time out. He said, I'll be definitely there to attend. And I think this is a passion by all, Dr. Singhal, Dr. Bhowmik, Professor Kher, that is visible, and that is how we are all here. I think, once again, a very masterly discussion. Professor Kher, sir, for your final comment, and then we can close.
No, I think we are done. I think most aspects have been discussed, and I feel that most of the aspects of reflux nephropathy, both presentation, the current controversies, as well as that surgery may be required in a very small percentage of people at all, very few select patients. By and large, this is something that is good for understanding the pathophysiology, how things happen, how scars are formed, but they may have other areas which are still not known. How does progression occur in this kind of a patient, and how we should be able to prevent progression and retard progression, I think, is important components of management. And I think kudos to both Bhowmik and Manoj and Dr. Biswas. You did very well.
Thank you, sir.
For presenting this patient. And I think the only thing I would suggest is tomorrow you should go to the lab and look at this albistics and maybe do a urine exam. Okay. Thank you very much. And I think we must thank
Microlab.
Mr. Raja and Microlabs for all the technical and other support that has been given constantly by them. Thank you very much for everybody, and thank you, Dr. General Varma.
Thank you, sir.
Thank you, sir.
Bye-bye.
Thank you.
Good
Bye-bye.
night.
Thank you very
Good night.
Good night.
Good night. Good night.
Good night.
Bye-bye.
Thank you, sir.
Good night, sir. Good night.